For MEK inhibitors, common side effects include morbilliform rash, alopecia, changes in hair color, acneiform rash, xerosis, and paronychia. Let's go through each one by one. A morbilliform rash is maculopapular. This means that there are macules, which are flat, discolored spots on the skin, as well as papules, which are raised bumps. Lesions are often on the torso and extremities, but spare the head and neck. For treatment, counsel the patient on gentle skincare. You can refer to our videos on tips for gentle skincare for more details. For grade 1 toxicities, emollients are sufficient. For grades 2 and 3, the patient can use oral antihistamines. Mid to high potency topical steroids like betamethasone valerate 0.05 or 0.1% or mometasone can also be considered. Ointments are preferred over creams since they are generally more effective. For more severe or refractory eruptions, consider oral steroids. At times, dose reductions or temporary holds of the medication might be indicated. Non-scarring alopecia can be treated with topical minoxidil 2 to 5%. Long-term treatment, usually for 6 months or more, is required to observe any improvement. Treatments must be continued indefinitely to maintain these improvements. Other changes to the hair seen with MEK inhibitors include changes in hair color. An acneiform rash is papulopustular. This means that there are raised red bumps, called papules, as well as lesions containing white or yellow pus, called pustules. While the rash looks very similar to typical acne, there are no white heads or black heads, known as comedones. The head, neck, and upper torso are more commonly affected, usually in a symmetrical distribution. A similar rash, known as a folliculocentric eruption, can present with a follicular distribution anywhere on the body. Treatment involves counseling on gentle skincare. For grade 1, patient can take dilute bleach baths and may be prescribed low-potency topical steroids. The patient may also be prescribed topical clindamycin or topical dapsone to control inflammation. For grade 2, mid-potency topical steroids and oral antibiotics can be used. Doxycycline or minocycline can be used for children over 8 years old, and macrolides or cephalexin can be used for those less than 8 years old. For grade 3, dermatology input may be required for consideration of other systemic therapies, including steroids or retinoids. Dose reduction or discontinuation may also be required. In xerosis, you will see dry and scaling patches. There may be diffuse areas of dryness on the body and/or cracking at the corners of the lips. In terms of treatment, counsel on gentle skincare. For grade 1, emphasize dry skincare with emollients. Low-potency topical steroids may be added if needed. For grades 2 and 3, the patient can take dilute bleach baths and may be prescribed a mid-potency topical steroid ointment. Paronychia is inflammation around the nail. It can be identified by redness, swelling, or cracked skin around the nails. Sometimes infection goes along with this inflammation. To treat paronychia, counsel your patients on nail care. Refer to our video on tips for nail care for more details. You should also examine the nail to rule out acute infection or abscess, which would require oral antibiotics or incision and drainage. Consider swabs for bacterial culture if signs of infection are present. For grade 1 toxicities, the patient can do warm soaks with dilute bleach or vinegar 3 times a day, and tension taping at night may be considered. For grades 2 and 3, add a mid to high potency topical steroid ointment and/or topical mupirocin. Consider oral antibiotics if there are signs of acute infection or swabs for bacterial culture. Dose reduction or discontinuation may be required.